Chronic inflammatory disease of airways.
Chronic inflammatory disease.
Which is reversible, sir.
Where there is
Reversible airflow obstruction. Yes, that is the first characteristic we have to say. So, it is a reversible airflow obstruction in patients who have a hyperreactive airway and it is an inflammatory condition affecting the lungs. That is the definition of bronchial asthma. What is the difference between intrinsic and extrinsic asthma? Have you heard of these two terms? That there exists a classification called intrinsic and extrinsic asthma. Are you aware of it?
Sir, intrinsic is in from the childhood it is there, sir. Extrinsic it's acquired after possibly in adulthood after
Adulthood.
exposure to allergen.
in extrinsic, mostly the skin test will be positive, sir.
Which is IgE mediated, which is non-IgE mediated.
Extrinsic is IgE mediated.
That is, extrinsic is also known as allergic asthma brought by airborne substances like pollen, dust mites, dander, and usually begins in childhood or early adulthood. Okay? And involves systemic IgE, immunological mediated antibody reaction to specific allergens. So if these three characteristics are there, it is called extrinsic or allergic asthma. Intrinsic or non-allergic, brought about by respiratory infections, cold air, exercise. Intrinsic means within the body, changes occurring within the body. Extrinsic means something coming from outside. You remember like that. And not intrinsic is cold air, exercise, stress, etc. And more commonly develops in adults, often after the age of 40, does not show systemic allergic reaction or elevated IgE levels. So it is more difficult to diagnose. Okay? So non-intrinsic, non-allergic or intrinsic is non-IgE mediated. What are the causes of intraoperative tight bag? How do you manage it? Supposing you are anesthetizing an asthmatic patient for lap cholecystectomy, and as soon as you have intubated, the bag is very tense and tight, you are not able to squeeze the bag before you switch on to the ventilator. And patient is starting to desaturate.
Any
This is called the
secretions,
tight
sir?
bag situation. So how to manage that?
Blocked
Any secretions,
blocked endotracheal tube, sir.
Pardon?
Endobronchial intubation or bronchospasm.
or any secretions of mucus plug,
Very good.
Pneumothorax.
or any anaphylaxis.
Very good.
Any displacement of the tube.
This,
ET tube displacement, sir.
Anybody else who can answer as we have to answer in the examination?
Pneumothorax also, sir.
Pneumothorax, very good. All are correct. I am not denying. But how to answer this question in the exam? What all you have now answered, it all arises from the patient only, isn't it?
Yes, sir.
Can there be a condition which can be caused by the machine?
Yes, sir.
So the first thing answer in the exam they expect you is to say this. Intraoperative tight bag can be due to machine causes and patient causes. This is the first answer you have to give. Okay?
Okay,
So what are the machine causes you can think of?
Kinked or blocked the endotracheal tube, sir.
Kinked or blocked endotracheal tube. Very good.
Breathing
Then
circuit blockage, sir.
high flow rate itself sometimes can cause it. Supposing you are keeping 10 liters oxygen for pre-oxygenation and you have not reduced it, or accidentally the oxygen flush valve is operated and it is stuck in a position and more oxygen is coming. Or there is a kink in the circuit or the reservoir bag. All these things can produce tight bag. Okay? So kinked, biting or blocked endotracheal tube, endobronchial intubation, closed or malfunctioning APL valve, blocked HMA filter, closed to circuit or components, or twisted or defective reservoir bag. These are all causes of machine causes for tight bag. Patient cause, it can be asthmatic bronchospasm, or it might be a pneumothorax, it may be aspiration, it may be pulmonary edema, it may be inadequate muscle relaxation. Patient may be bucking or coughing on the tube, anaphylaxis, and pulmonary embolism. All the answers you have rightly given, they all belong to patient causes. Now the next part of the question, how to manage it. Supposing this situation arises when you are anesthetizing, what is the first thing you will do?
100%.
100% oxygen. Then,
Oh,
if you give 100% oxygen, will the spasm get relieved?
Mm,
no, no,
no,
no.
sir.
Hmm.
We'll check for the any blockage or disconnections, any blockage in the kinked
How do
or
you
blocked
check that?
circuit, sir.
Manually ventilating, sir.
With what?
Self-inflating bag.
See, the first answer is disconnect from circuit. Immediately disconnect the patient from anesthesia machine circuit. Ventilate with self-inflating bag and manually ventilate the patient with 100% oxygen. Okay. Now, how do you find out whether by doing this, what do you find out?
Uh,
By disconnecting the patient and trying to ventilate with the ambu bag or a central ventilative bag, what can you find out? Can you differentiate between machine and patient causes here?
Yes, sir.
yes,
If
sir.
If you
able
are
to
able to
ventilate,
ventilate,
it's
what does it mean? If
Ventilate.
you are not able to ventilate, what does it mean?
able to ventilate as machine cause, sir.
It is
Patient
a
Not
cause.
machine
able to
cause.
ventilate.
If you are not able to ventilate, it
It's
is
a
a
patient
patient.
cause, sir.
Patient cause.
Yeah, that is.
Yes, sir.
That's simple as that. Determine the origin. If the bag remains tight with the ambu bag, the problem is patient related. If ventilation is easy with the ambu bag, the problem is equipment related. Okay. So these are all the answers that you have to give in the exam. Don't start with 100% oxygen. I'll try to suck out or try to see whether that all that. Not this is the way to answer the exam. Disconnect the patient from circuit immediately. Do manual ventilation with an ambu bag. And if you are able to ventilate, it is a machine fault. If you are not able to ventilate, it is a patient. What is AHA classification of hypertension? How is it classified based on the etiology? Sorry, there is a small jumble in the order because I was already preparing to complete the slides. I think till 2 a.m. last night.
So,
So,
stage
Normal
2, 3.
normal blood pressure, sir. Elevated. Stage 1 hypertension, stage 2 hypertension,
stage
sir.
2 unfamiliar. Very good.
And
So, based on the
hypertension.
etiology,
Severe hypertension. Mm.
that is the AHA classification. What you have said is very, very correct. Normal, elevated, stage 1, stage 2. And normal, what is the value?
So less than
Normal is
120,
less than
120,
120.
80. Then
80.
earlier it was 130, 80. Now they have reduced it to by another 10 millimeters. So 120 systolic, 80 diastolic. What is elevated?
It's less than 130, so 120 to
Systolic is
128.
elevated, but diastolic is same,
Systolic is
80.
80.
And stage 1, both systolic and diastolic elevated to some extent. Stage 2, further elevation. Okay? But based on the etiology, how can you classify hypertension?
Primary and
Primary
secondary
hypertension,
Primary and
secondary
secondary.
hypertension.
Fantastic. Okay. So AHA classification, normal 120/80, elevated systolic between 120-129, diastolic under 80. Stage 1, systolic 130-139, diastolic 80-89. Stage 2, systolic more than 140, diastolic more than 90. And they're based on etiology, it is primary or idiopathic and secondary hypertension. What are the common causes of secondary hypertension?
Hyperparathyroidism, pheochromocytoma,
Pheochromocytoma, sir. Renal
acromegaly,
stenosis,
Hmm.
renal artery stenosis.
Endocrine,
NSH,
renal, like that you can classify them. Okay? Endocrine is pheochromocytoma and Cushing's disease. Renal is renal artery stenosis or CKD. And
coarctation of aorta.
coarctation of aorta. What is the current guidelines on threshold of BP for elective surgery? Supposing a patient has a BP of 150/100, will you accept him or not?
150/100, sir.
Hmm.
Current
Current guidelines
okay.
recommends BP of 180/120. Up to that, you need not cancel the case. Current guidelines recommend proceeding with elective surgery if the patient's clinic blood pressure is below 180/120 or ambulatory or home BP is below 175 and 115. Okay? Provided there is no acute end organ damage like a recent stroke or a recent problem like retinopathy or reduction of some renal impairment. If this is not there, if there is no evident end organ damage, even if the BP is high, elective procedures need not be cancelled. Okay? What is accelerated hypertension? What is malignant hypertension? How are they differentiated?
Accelerated hypertension has no end organ damage, sir.
And malignant hypertension, you have end organ. How do you differentiate? What is the method of saying? Because in both the things, patient's BP rapidly increases from the original baseline BP. That is the definition of accelerated or malignant. Okay? The patient who was having a BP earlier of 130/80, suddenly if the BP goes up to 220/120, that may be accelerated hypertension or malignant hypertension. So differentiation, accelerated hypertension defined by a rapid significant rise in blood pressure from patient's baseline accompanied by early signs of vascular damage in organ. Whereas malignant hypertension, considered a more advanced and a specific subtype of this crisis, characterized by severe microvascular damage and a distinct pathological feature called fibrinoid necrosis. Okay? And to differentiate between the two, you have to look at the fundus. Fundal changes are nearly normal in accelerated hypertension, but fundus may show grade 2 to 3 retinopathy in malignant hypertension. So that is how you differentiate. What is alpine anesthesia in hypertensive patients? I think we have discussed this in the class.
It's a term where mark the swings during BP during induction and emergence. Followed by marked hypotension. First increased BP, followed by
fluctuating blood
decreased
pressure.
BP. Fluctuation.
Suddenly
Yes,
it
sir.
goes up, suddenly it comes down.
Yes,
So
sir.
that sort of fluctuant blood pressure producing mounds and valleys like the alpine mountains. Okay, that is what is called. So large sharp swings in patient blood pressure going up and down like mountain peak and valley during general anesthesia. That is what is called alpine anesthesia. What is seen in this X-ray?
Chest it's a chest X-ray showing PA view, sir. Showing left pneumothorax with left lung collapse, sir.
Very good. What about this?
Trachea is deviated to the right side, sir.
Phase deviated to the right. All that should be correct. Okay, this is an X-ray chest view. No bronchovascular markings are seen on the left side. Deviation of trachea, air shadow to right. Dark air shadow in the entire left pneumothorax. Collapsed lung unseen. So it's a case of tension pneumothorax. Why do you say tension pneumothorax? Because of this axial deviation. Okay. Whereas in the normal small pneumothorax, trachea will be in the midline. It will not be shifted. Okay? And this collapse will be only partial. It will not be so close to the mediastinum. What are the causes of pneumothorax?
It could be
trauma.
spontaneous or a
Trauma.
traumatic cause, sir.
We have discussed in the OSCE.
Yes,
This
sir.
X-ray I have picked up from the earlier OSCE slide only. I made this new slide. How do you classify pneumothorax first of all? Spontaneous and
Spontaneous
acquired.
Traumatic.
acquired, sir.
Traumatic comes under acquired. First is spontaneous, okay, primary and secondary. Spontaneous primary occurs without apparent cause, often in tall young adults due to ruptured air blisters or blood. Okay. Spontaneous secondary occurs from underlying lung diseases like COPD, asthma, or cystic fibrosis. The acquired can be traumatic, caused by blunt or penetrating chest injuries, and it may be iatrogenic, triggered by medical procedures like lung biopsy, paracentesis, or central line placement. Okay. How many of you have created pneumothorax by placing central line? Any of you done that?
No, sir.
No.
Oh, great. So, how to identify pleural injury during supraclavicular brachial plexus block? How to manage pneumothorax due to pleural puncture happening during this procedure?
The patient will have sudden pain with cough, sir.
Cough.
Cough.
More than pain, patient will have incessant or recurrent cough. Very good. Then, supposing you are punctured and there is a pneumothorax, should you put an ICD to that patient?
No, sir. Will observe.
Observe, yes. So, what are the criteria to manage a known pleural puncture case? So, patient will have recurrent cough if pleura is injured. That is how you identify pleural injury. Treatment of pneumothorax is based on the size. So, no treatment is required if the size is less than 20%. And how to calculate the size of the pneumothorax?
Size.
This also I have shown in the earlier OSCE slides during the class. Let me see how many of you remember that. You have to, I will give you a clue. You have to take an X-ray chest. Can you remember or recall? So, you take an X-ray chest. First, measure the size of the hemithorax on the side of the suspected pneumothorax. So, this is the outer line, blue line, is 15 centimeters breadth and 30 centimeters in length. This is the outer hemithorax. So 30 into 45, what is the volume? 450.
Perfect.
Okay. And there is a collapsed lung area because all the other is air. This is the collapsed lung area. That is the mark, and that comes to 7 centimeter into 13 centimeter. Okay. So the total hemithorax volume is 13 to 15. Atelectatic lung area is 13 into 7. So size of the pneumothorax A minus B, that is hemithorax minus the atelectatic lung, divided by the volume of the pneumothorax multiplied by 100, that is the percentage. Okay. So 450 minus 91 divided by 450 into 100 is the percentage. Okay. What is shown here?
Triangle of safety.
Safety.
Triangle of safety. Safe triangle for ICD insertion. Very good. Name the boundaries of this said triangle.
It's formed by
The medial,
lateral.
is the lateral, the apex,
So,
and it's the base.
superiorly base of axilla, inferiorly fifth intercostal space, posteriorly latissimus dorsi, and anteriorly pectoralis major.
Pectoralis major.
These are all the lateral edge of latissimus dorsi. Pectoralis major, fifth intercostal space. Okay, these are the. What is so seen here?
Intercostal
Hmm?
important system of intercostal drainage.
This is the 1, 2, 3 bottle underwater drainage system. This is 1 bottle drain, this is the 2 bottle drain, this is 3 bottle drain. Okay. I showed all this in the earlier class and showed and told the purpose of these different types. What is needle decompression of pneumothorax?
Um, it is done to relieve the immediate
It's an emergency
emergency
procedure. Okay?
procedure.
When there is a
Tension
tension pneumothorax and you don't have access to ICD drain or all these bottles, to save the life of the patient, you have to do it as an emergency life-saving procedure. It's an emergency life-saving step for treating tension pneumothorax. How do you do this?
Mhm.
Everybody, all anesthetists or all medical officers, in fact, all doctors should know how to act in a emergency tension pneumothorax situation by knowing this procedure. It's not only for anesthetists. Every doctor should know to save the life of the patient. It's a very simple procedure. Okay. So how is it done? You have to insert a 18 gauge IV cannula into the affected side in the second intercostal space in the mid-clavicular line. This is the mid-clavicular line. This is the second intercostal space. So you just push a 18 gauge wet cloth into this space. Because it is filled with air, you will not injure any structure. And once you enter into the pleural space, air will gush out. What you do is you remove the needle and then connect the cannula to an IV set and put it into an underwater bottle, the drainage seal. Okay. So connect the cannula to an IV set and connect it to underwater seal. You will save the patient's life. Okay. That's what's called emergency needle decompression. You can also aspirate using a syringe, but that will take a long time. So this is the emergency life-saving procedure. Some more questions about the drainage system. Okay, what is shown in this? Again, 1 bottle, 2 bottle, and 3 bottle system, intercostal drainage system. What are the indications for it? What are the indications for the ICD?
pleural effusion,
Pneumothorax, pleural
pneumothorax.
Whenever
pneumothorax,
you want to drain
pneumothorax,
something
pleural
that is
effusion,
collected in
empyema.
the pleural space, okay, maybe fluid, air, blood, anything it may be there, to drain air, blood, or fluid from pleural space. And what should be the height of the bottle? Of course, nowadays you have this disposable plastic sets which are connected to all thoracic or cardiac surgeries. So you don't commonly see in this, but examiners may be sometimes trying to teach you by asking these questions. Okay? So the height of the bottle, that is, what should be the height of water in the bottle? The water level, it should be at least 2 centimeters.
Centimeter.
The advantages of 2 bottle system.
Um,
What is the advantage
it
of this? Hmm?
it prevents the backflow of air.
You can exactly find out, separate the fluid collection in the bottle, fix the underwater sea level, and no froth formation will happen because it's both the fluid and secretions will not mix in that. So you can identify the amount of liquid drained from the pleural space separately. The advantages of three bottle system. This is the
suction
you can accelerate or you can speed up the expansion of the lung by sucking out the air from the pleural space. An adjustable pressure suction drains both fluid and air, and no reflex back of the fluid will happen. There will not be any back. So this is just identification. This is what is this case?
cleft palate, sir. It is
Cleft palate. Very good.
Cleft palate.
Incomplete cleft palate. Okay. You have to say what is whether it's complete or incomplete. What is this?
Post burns contracture with
Post-burn arc contracture of the neck. What is this?
non-healing ulcer.
Non-healing ulcer in the foot, probably diabetic ulcer.
Diabetic.
What is this?
Tracheostomy tube with a mask.
Oxygenation. Okay. The oxygen delivery through the liquid.
Okay.
Right. Another short case. What is shown here and how does it work?
So, MRI.
This is an MRI machine. The patient inside the MRI. Very good. So this is an MRI machine. This procedure, how does it work? What is the mechanism of functioning of MRI? Okay, so there is strong magnetic field which within the body the hydrogen atoms of the water become aligned either in the same or opposite direction of the magnetic field. Okay, so it is mainly by aligning the hydrogen atoms in our body, which is part of our water. Okay, H2O. So a pulse of electromagnetic radiation directed towards the body causes the hydrogen nuclei to rotate from their equilibrium. And when this rotation is removed, the nuclei emit radio waves as they return to original equilibrium position. And this radio wave signal is detected by a coil in the scanner and processed by computer to produce visual display. So these are the four things. They first attack or make the hydrogen molecules to rotate towards the magnetic field or away from that, and then you pass a electrical stimulation and radiation stimulation, electromagnetic radiation, and try to scatter them, and then you remove that radiation, then they go back to their original alignment. During that time, a signal is produced that will be detected by a coil, and then it is processed in the computer to produce the visual display. What are the components of an MRI scanner? So there is a main magnet producing a magnetic field. Then there is a coil. These are all the parts already I have been told. So there is a primary magnet, gradient magnet, radio frequency coil, and there is a computer system. Just four components, remember. Primary magnet, gradient magnet, radio frequency coil, and computer system. What are the features of primary magnet? This is a coil of wire made of superconducting material through which current is passed. This material has no resistance below minus 260 degrees and can produce a very large magnetic field. And to achieve this temperature, the wire is kept in the liquid nitrogen and helium. Okay? It is immersed in that. What is Tesla? Whenever you are seeing a image MRI report, it says 1.5 Tesla.
Unit of MRI.
It is the strength of the magnetic field. It is the unit of magnetic flux density. And another unit is called the gas. Okay? 1 Tesla is equal to 10,000 gas. What is meant by T1 and T2 weighted images? Usually when you read the MRI report, this is the first line you will see. non-contrast enhanced or in contrast enhanced T1, T2 weighted images show such and such things. So it is a relaxed T stands for relaxation time. Okay, relaxation time constant, and they measure how the nuclei relax back to their original position. And in T1, fluid will look dark, whereas in T2 images, it will, for example, if you take a picture of the brain, MRI brain, if it is T1, the CSF will look like a black and all the structures will look white. Whereas in a T2 image, the CSF will be white and other structures will be dark. Okay? The examination, sometimes they may give you such MRI pictures and ask you whether it is T1 or T2. Please remember, in T1, fluid is black. Remember CSF easily. CSF will look black, and in T2, CSF will look white. Continuation of that, again here it is a MRI anesthesia being given. You can see the anesthesia machine. What are the indications for anesthesia requirement in MRI suit?
Claustrophobic patients.
Claustrophobic patients, pediatric, mainly
Pediatric
pediatric patients, you cannot stay still because you require a quiet patient to lay in a particular position because movement will distort the images. So anesthesia needed for children and uncooperative adults. What is MRI safe equipment? There are two terminologies which you have to know. One is MRI compatible and other is MRI safe equipment. It's a small difference
MRI
between these.
MRI safe, it contains no magnetic material. There is no any hazard, sir, and MRI compatible is where the anesthesia machines and the ventilator they are compatible.
Okay. MRI safe equipment, they have no safety issues when taken into the suit. Their function is not guaranteed. It may interfere with the MRI operation itself. Okay? So they will not be attracted by the magnetic field like a metal or a dental prosthesis or a metal clip in your joints. All these things will not be attracted if it is an MRI safe equipment. They have no safety assured that it will be snatched away by the magnetic field, but it will not guarantee the functioning of that particular equipment, or it may interfere with the operation of the MRI itself. That is called MRI safe equipment. Whereas an MRI compatible equipment is both MRI safe and does not interfere with the operation of the MRI as well as of the equipment. That is called compatible. So where the main difference is, it will not, MRI safe equipment will not physically get attracted towards the magnetic field, but it may interfere with the MRI operation. Whereas MRI compatible equipment will not only be attracted by the magnetic field, will not interfere with the MRI operations also. So Tesla, of course, is the strength of the magnetic field. Another unit is the gas, and 10,000 gas is 1 Tesla. Tracheostomy is also kept as a short case in the exam. So what is shown here? Are you not able to see? Am I audible?
Surgical tracheostomy.
What do you see here? All of you have become tired so soon. என்னம்மா அது யாருமே ஐடென்டிஃபை பண்ண முடியலையா? Tracheostomy in situ. Tracheostomy tube in situ. A small child. What is the purpose of these threads that are being taped here? Are you seeing some blue threads which have been fixed with the tape?
Securing the tracheostomy tube.
What is the name of those threads? They're called stay sutures. Okay? At the edge of the wound, they will put these sutures and keep it ready. And what is the purpose of that? Can be used to identify the opening during tube changing. Otherwise, sometimes that will collapse. And they are useful to close the hole after decannulation. What are the indications for tracheostomy in children?
Mm,
Of course, it is not specifically for children, for any patient. What are the indications for tracheostomy?
uh, Prolonged mechanical ventilation, any spinal cord
Whenever you need
injury,
prolonged
spinal
mechanical
cord injury,
ventilation, very good. Then
spinal cord injury, trauma,
spinal cord injury.
or spinal cord trauma, sir.
Supposing there is a lumbar spine injury, will you need a tracheostomy?
Oh, sir. Any
To facilitate long-term respiratory support, clearance of secretions, and treat fixed upper airway obstruction. These are the common indications for tracheostomy. What anesthesia is provided for tracheostomy if it is a pediatric patient? Adult patient, of course, we can do it under local infiltration. But in a child, they may not cooperate, especially if they are conscious. So what is the
general anesthesia?
general anesthesia with endotracheal intubation? Supposing there is an upper airway obstruction, there is injury to the larynx. So IV sedation with LA infiltration, GA with oral or nasal intubation is the choice for anesthesia. And how to position the child for tracheostomy, or for that matter any adult patient. Have you ever seen a tracheostomy being done
Yes,
in the
sir.
ICU?
Yes,
Ah,
sir. Yes, sir.
You want the neck to be flexed or fully extended?
Extended.
Fully extended,
I
sir.
told her please
Extended.
answer little fast, ma, otherwise I cannot finish the whole thing. Child is positioned supine with their whole place under the shoulders and neck extended to expose the trachea. And small children may also need a strap to be attached to them. Okay? Now, this humidification provided for patients with tracheostomy. If you don't provide humidification, there will be the air passage may get dry because the
Um,
esophagus is not being used now for respiration.
it
Hmm?
HME filter, sir.
HME filter is one very good. Then
Humidified
how does your
oxygen. Humidified oxygen.
humidification methods include heat and moisture exchanger, that is XME, saline nebulizers, continuous humidification via water humidifier. So these are all the options. What are the complications of tracheostomy? This is a very common
Bleeding,
question.
Dislodgement of the
bleeding,
tracheostomy.
tracheal stenosis,
Stenosis, very good.
drying of the
All
mucosa.
of your answers are very, very correct. But in the exam, there is a pattern expected by the examiner in your answer. Okay. So the pattern you have to say is immediate complications, first few hours. Loss of airway, bleeding, pneumothorax, pneumomediastinum, surgical emphysema, esophageal injury, recurrent laryngeal nerve damage. All these things are immediate. Then intermediate, which can happen during the first 10 days, tube dislodgement, tube obstruction, secretion, bleeding, infection. Long-term granuloma, vascular erosion, issues with neck skin integrity, tracheal stenosis. Okay, this is how you must answer in the exam. So even though the conditions you are mentioning are all right, if you answer in this pattern, you will get good marks as well as appreciation. So please always try to go in a orderly fashion, immediate, intermediate, and long-term complications. Now coming to the malignancy cases, we have CA cheek, tongue, breast or ovary cases. Something peculiar for each one will be there. So this is a picture of a CA cheek, a picture of a CA tongue. What are the problems in anesthetizing these patients?
They come under a
Difficult
difficult
airways.
airway, sir.
They may come under difficult airway as well as typical post-operative airway management, because they may be resecting the mandible part of the tongue, cheek, and putting up the flap. So post-op airway management. So pre-op difficult airway, anticipated difficult airway, as well as post-op difficult airway management. Excellent. These are the two problems in that. Anything additional to that? If supposing patient had a radiation before coming for surgery, will it add up to the difficult airway?
Yes,
Yes, sir.
it will.
How does it cause more difficulty?
There will be a restriction of
Causes fibrosis of the normal tissues also and cause contracture. Okay? Radiation will shrink the tissue and that will make positioning very, very difficult. So neck extension may not be there, mouth opening may be restricted, so all these things will happen. Okay? So that CA oral cavity, difficult airway before anesthesia, post radiation effects, post of feeding also will be a problem because they cannot swallow. So you have to take care of their nutrition also. Now, in case of CA breast, what are the what is the current treatment for CA breast? Do they do radical mastectomy or
breast
some other procedure?
Modified
cancer
radical.
Modified radical mastectomy with
Lymph node dissection.
lymph node thickening or axillary clearance. Okay, that is with a procedure that is being done. So, what are the current methods of giving anesthesia for breast excision in CA breast? We always give GA, or are there any regional blocks which are expected
Now there
from
is
Blocks,
PEC 1,
PEC
PEC 2
1 and
block
PEC
as
2
well, sir.
blocks.
PEC 1 and
PEC
PEC 2
1
block.
PEC 2 block.
PEC 1, PEC 2 block, very good. Then anything posterior,
Yes, sir.
paravertebral block, very good.
Paravertebral block.
Erectus spine
Intercostal
block
block.
can also be given, sir.
Okay, so they are called facial plane box.
Facial
Okay?
plane.
And patients who have had a chemotherapy prior to breast excision, some advanced cases, you must know all about the effects of chemotherapeutic drugs on the various systems. So, what is the most weird complication of chemotherapy? Which system is likely to be very much affected by a drug called
Cardiotoxicity.
doxorubicin?
Cardiotoxic.
Cardiotoxicity, very good. So you have to ask for this and make sure that cardiac system is not affected. And cancer ovary may go. What is this RO surgery? What is the other name for this?
Reductions.
Cytoreductive surgery or residual zero surgery. It is zero residue. So they try to remove as many visible metastases as possible and do what is called cytoreductive surgery, and they may sometimes do hypec surgery also. So you must be ready to answer about these things in this sort of malignancy cases. Now, coming to the very commonly kept case, cleft lip and cleft palate. Can you identify each type of this cleft and what is A, B, C, and D?
Is
Incomplete. Unilateral.
Always you must say unilateral or bilateral.
unilateral
Whether it is complete or incomplete.
Second is incomplete unilateral cleft lip.
A is
Unilateral
A
incomplete.
and B are incomplete
Uni-
unilateral cleft
Unilateral
lip,
cleft
right
lip.
and left side.
Right and left
Okay,
side.
so this is on the right side.
V
left side, they are incomplete because they are not going into the nasal sill or floor of the nostril. Okay, supposing it is a complete like this, it would have gone into the nasal floor and the ala would have been distorted like this. And this is the columella. This mid portion, which is the upright portion, is called the columella. So they will all be away. And so C and D, this is a unilateral cleft lip on the right side. This is a bilateral cleft lip. Both the sides are cleft. So the C and D is complete cleft on the right, bilateral complete on the left is the D. What about this bottom ones?
Unilateral.
complete.
Left
This is
palate.
incomplete.
Complete palate, cleft
Cleft
of the
palate.
palate. Okay, this is complete cleft,
Cleft.
including the alveolus and also the lip. Okay, there is no lip cleft. This is a purely incomplete cleft of the palate because the hard palate is not affected. Whereas in a complete cleft, both hard palate and soft palate will be separated. And here there is a continuation with the lip also. So this is the complete cleft of the lip on the left side with the left palate. Okay, right. What is the embryology of cleft lip and palate? This is also a common question. I think we have discussed this earlier in the class. In just simple 2 lines, you can answer this.
Maxillary sinus with
Maxillary
Failure of
protuberance.
fusion of 2 elements. One is the nasal process, another is the maxillary
Maxillary
process.
Maxillary
They
process.
two have to unite. They don't unite. That's all. Very simple. Okay. Formation of lip and palate start at the 4th week of gestation, completed by 12th week. That is within the first trimester. Failure of fusion of frontonasal process with the maxillary process results in all sorts of clefts. Okay. So remember these two, frontonasal process, that is something coming in the midline. It is joined by 2 processes from the lateral side, maxillary process. And what are the common complaints that patients, attenders will make when the patient has a lip or a palate defect?
inability to suck, so feeding difficulty.
Feeding difficulty. First and foremost, as soon as the child is born, will they complain of feeding difficulty? They notice something abnormal in the appearance, isn't it?
Yes, sir.
The child has got a cleft lip,
Congenital anomaly.
they will look, appearance is defective. Complaints inform regarding appearance, then feeding difficulty, then recurrent infections in chest and ear, speech abnormality according to the time of presentation. Okay. What specific examination need to be done?
Hemoglobin.
All cases of congenital deformity, first and foremost, in the clinical examination. What is the other thing? Look for other congenital anomalies. Okay, examine the child for appropriate age, growth, development. Look for other congenital abnormalities or whether this is a syndromic cleft. Okay, that is the thing that examiners always expect. Whether it is a syndrome associated with the cleft or whether what is the common cardiac anomaly which may be associated with cleft lip and palate?
VSG.
Genetic cardiac anomaly.
VSG.
The first slide we started with today's class. VSD. Okay. Which type of cases are likely to pose difficult airway? There is a cleft. Which type of or which classes of cleft lip and palate you may anticipate difficulty in intubation?
Bilateral cleft lip and complete palate.
Bilateral complete, very good.
And
Complete.
cleft palate, sir.
Left-sided complete. Okay,
Left side.
left-sided wide cleft, bilateral cleft with a protuberant premaxillae, or syndromic clefts like Peary-Robin, Pritchard-Collin, or Little-Field syndrome. Okay, they are all, you have to anticipate difficult intubation. What investigations are needed?
Hemoglobin,
Hemoglobin.
blood count, sir.
Hemoglobin,
Total count, sir.
total count, very good.
And
Blood grouping and cross
X-ray
matching.
test if there is history of repeated infection. Okay. Minimal investigations like HB, CXR if there is a recurrent LRI, ENT opinion for OSM, and opinion for deficit difficulty, dental opinion, cardiology opinion if there is any associated congenital cardiac anomaly. What is a common congenital anomaly? Of course, we have answered that. This is VSD. And I'm showing something here. What is shown here? How is it helpful?
Obturators.
This is called an operator. Very good. So this is what is the use? How is it helpful?
It is pre-shaped as
It's a mold,
the
acrylic mold
pre-shaped.
to
Yes.
close the cleft. So by closing the cleft, what can you achieve?
you can intubate easily, sir.
You can prevent aspiration. And while bleeding, if you put this, the gap will close. So patient will not aspirate. So it is helpful during this what is called an acrylic mold called operator. It helps to close the cleft in alveolus and palate during feeding, and this can also help during intubation by preventing the laryngoscope blade getting caught in the cleft. What is Kilner's rule of 10?
Weight of the child has to be 10 pounds, sir.
It is a rule
Hemoglobin
followed
10.
for selecting patients for cleft lip surgery because they are lip is done at a very young age. So one surgeon called Kilner recommended some rule where post-op results are better and the complications are less if you follow that for lip surgery only, not for palate. So the fourth rule sense that he advocated weight is about 10 pounds, not 10 kg, and the age of the child should be 10 weeks, 2.5 months. And what should be the hemoglobin?
10
10
grams, sir.
grams.
10 grams. And what should be the total count?
10,000, less than
Less
10,000.
than 10,000. Okay. Kilner's rule of 10 used for selecting patients for lip repair, age less than 10 weeks or 10 weeks, weight 10 pounds, hemoglobin 10 grams, WBC less than 10 kg. What are the types of induction in cleft babies? How is it chosen? Induction, we have only two types in anesthesia.
Inhalation and IV
Inhalation and intravenous.
Intravenous.
So when will you choose intravenous? When will you choose inhalation?
When the IV access is not available, we'll
If
do
IV access is not available, you can go for inhalation. Very good. Then
if present, we can do IV induction, sir.
little louder, please. I am not able to hear. Who is that answering?
Bindu, sir.
Bindu, little louder, Bindu, or increase your volume audio.
Yes, sir. If the IV access is present, sir, we can do IV induction, sir. It is an anticipated difficult airway, sir. Hence, we can use.
Two types of induction are possible: inhalation versus intravenous. Inhalation induction is preferred in anticipated difficult intubation or where difficult IV access is there. So, what pre-op calculations are important in these babies? What are all the things you must calculate whenever you have a child for a lip repair? Because they are all very small made, their weight may be very, very less because they are only 3 months old. They may be 3 kg, 4 kg. So what important
allowable
calculations
blood
we have
loss.
to make?
Allowable blood loss.
Drugs as well as fluids.
Drugs
All
and
drugs should be diluted to administer the correct dose based on the body weight, and fluid requirement to be calculated according to Holiday's HR formula and filled in the Burette IV sets. Otherwise, you are likely to overload the patient, give overdosage to the patient also. Describe the method and challenges of providing anesthesia for cleft lip. What are all the steps in providing anesthesia? Supposing you have a 3 months old baby coming for lip repair. Have you
Infant anesthesia.
both of you exam goings, have you ever seen a lip repair being done in your hospital?
They have done,
No,
sir,
Yes.
but we have not assessed.
we have not seen.
Have you seen or not?
No, sir.
No, sir.
Not seen. Nobody
Yes, sir.
does that? Okay. Then I'll go ahead with that. So cleft lip anesthesia usually done before 3 months. That will be challenges of infant anesthesia. They are more prone for hypothermia, hypoxia, and induced bradycardia is very, very common in them. It may have difficult IV access. The chances of endobronchial intubation because the tracheal length is very short. And there is no need for pre-medication because there is no separation of childcare anxiety, and you have to follow starvation guidelines correctly because too long starvation will dehydrate the babies. For cleft palate, there will be older children prone for separation anxiety, more chances of difficult intubation also will be there. And OT preparation, the ambient temperature of the OT should be between 22 to 24 degrees. All anesthesia equipment should be checked before you bring the patient in. And required calculated fluid to be filled in the IV set. All drugs to be loaded and labeled. All airway equipment also has to be suction everything. Here it includes all anesthesia equipment, include airway, laryngoscope, the correct size tubes, the suction, etc. IV or inhalation induction done based on the indication, as I already said. You can use atracurium for intubation, oral ray tube for appropriate size for endotracheal intubation. Air entry checked after fixing the tube. Maintain the anesthesia with oxygen, air, or sometimes nitrous also. PO or ISO for inhalation. And positioning the head in extended position on a pillow, something like a tonsillectomy only. And check air entry after this and after the mouth gag application in palate surgery, and appropriate nerve block, that is the infraorbital nerve for lip repair and greater palatine block for palate repair, or infiltration with permission local anesthesia for palate. And monitors commonly used are ECG, pulse oximetry, capnography, temperature, and this precordial stethoscope is very, very important. Not forget all this. Analgesia, you can give multimodal, para, NSAID suppositories, fentanyl, delay block, and infiltration. Recovery, child should be fully awake with all reflexes intact, extubated in the lateral position after thorough suctioning of the oropharynx. What are the likely post-op complications, especially after palate surgery?
Post-op edema, sir, airway edema, bleeding.
Bleeding, yes, just as the post-tonsillectomy bleeding, they have post-palatal bleeding also. So, post-op recovery respiratory complications like obstruction, laryngeal spasm, aspiration. Post-op restlessness may be because of pain, hunger, or airway compromise, or separation anxiety. So, essential to identify and manage instead of blindly giving sedation. Some of the syndromes, supposing they have these patients, they may keep it here. These are all the common syndromes that may be associated with cleft lip and palate. I'm just going to show pictures of those patients. Can you identify this patient?
Down syndrome, sir.
Can see the gap between the two
Down
eyebrows.
syndrome. Yes, sir.
Down syndrome,
Intercalated
yes.
distance is
The
increased.
slanting eyes and the wide hypertelorism. This is called hypertelorism. The gap between the eye medial canthus is very wide, the eyebrows are very far apart. So this is the classical feature of a Down syndrome child. This, of course, you may not be very seeing. This is if you see too pitched in the lower lip, this is called Vanderwood syndrome. What is this syndrome?
Teacher, teacher.
You can see the ear defects here. So this Treacher-Collins
Richard Collins.
syndrome. What is this
Thierry
syndrome?
Robbins.
Thierry
Thierry
Robbins.
Thierry
Robbins.
Robbins. Very good. What is this syndrome?
Klippel
Where the shoulders are stuck.
Klippel-Feil
This
syndrome.
is the Klippel-Feil syndrome. Okay? And this is the Apert syndrome. Okay? So these are all the some of the anesthetic equipments used in cleft lip and palate surgery. They may ask you, what is this circuit that is commonly used in babies?
Jackson-Rees circuit, sir.
Jackson-Rees modification of ISTPs. That is the complete answer. Jackson-Rees modification of ISTPs. And it belongs to what category of Mappleson's classification?
F.
It's an E and F. Okay. ISTPs is Mapleson E and Jackson-Rees modification is Mapleson F. What are these?
Pediatric face mask.
Transparent
Transparent
pediatric
pediatric
face
face mask, sir.
Okay. Scented face mask. What is this?
Laryngoscope.
Various
Different
blades
plates
of
with a Macintosh laryngoscope.
Macintosh laryngoscope.
Single-handed burp application. So the anesthetist who is intubating the patient is using the left little finger with which he is holding the laryngoscope itself. Instead of somebody giving compression from the external, he is using his own fingers to apply the pressure. What is this tube?
RAE tube.
RAE tube. Pediatric.
Pediatric
Anything
RA.
else you have to say? Does it have a cup?
A cuffless, sir.
Plain. You must
Cuffless,
always
plain.
say plain oral
South Pole
South Pole tube. Okay? This is a history, not a specimen for history knowledge. These
Rubber.
were the tubes that were used before the advent of this tube for oral surgery, cleft lip and cleft palate.
Rubber tubes.
Rubber tube. It's made of red rubber, correct. Material is right. But any name for that? It's called Oxford ET tube. Okay? That was the tube we originally used when we were all postgraduates, but not now. And this is a metal connection used to connect this the rubber tube to the breathing circuit. Okay? This is called the McGill's metal connector. And this is the reservoir bag, which is normally used like this. They have a tail like this, but here there is no tail, but there is an opening in the center. The name for this, I have shown this in the OSCE earlier. It is called the Kund reservoir bag. KUHN, Kund reservoir bag. Now coming to the next start case, what is shown here?
Congenital Talipes equinovirus.
Congenital Talipes equinovirus. What are the treatment options?
The conservative method with Ponseti cast and
Cast
in earlier
application,
stage.
very good.
Later stages, a tendo-Achilles lengthening or
Soft tissue release, very good. So non-operative and operative treatment. So this is the what is being shown here.
tendo-Achilles.
Tendo-Achilles tendon release.
This is the closed tendon release. Okay? This is a closed tenotomy or a tendon release without the major incision, just using a small 11 blade knife and making of the tendo-Achilles. Okay? So you can use it by doing it under local infiltration or keeping in anesthesia. Other operative procedures are done already TA lengthening, which can be done with sedation and caudal block, or sedation and popliteal nerve block, or extensive soft tissue release you can do under GA with LMA or ET tube and caudal and nerve block. What are the landmarks for caudal block?
It is a triangle formed by sacral hiatus, sir, and bilateral.
Sacral hiatus is the opening. It is guarded by what? Sacral cornua. Okay, you have to say that. So say two sacral cornua with the tip of the coccyx forms the triangle. You will have a depression there, and you have to identify that. What is Armitage's formula?
Is used to calculate the volume of local anesthetics in caudal
Calculate the
block.
volume based
0.25%
on
BB
the level
vaccines,
of
sir.
block
Level.
required. Okay. So what is the volume required for perineal surgery?
For sacral, it's 0.5 ml per kg of 0.25% BB vaccines, sir.
0.5 and 1 ml for
Thoracolumbar surgeries.
To T10 level, sir.
beyond that
It's 1.25 ml
1.2
per kg,
ml,
sir.
but reduce the concentration to 0.2 instead of
0.2.
0.25. What is Woosh test?
Which, uh,
It is used to confirm the uh, drug entering in the caudal space, sir.
Identify whether you are in the caudal space. How do you do that? Just
after
like your
injecting the
epidural
needle,
loss of resistance, you just push air into the caudal space and auscultate whether you are able to hear that whoosh noise. If it is subcutaneous, it will only bulge out, it will not make a noise. Whereas if you are correctly in the caudal space, it will make that whoosh sound as the air going in. What are the complications of caudal block?
uh, urinary retention,
Accidental
subarachnoid block.
subarachnoid block,
Puncture
sir.
of the dura and total spinal bleeding. Okay, these are the two common things. How to assess the success of caudal block? Supposing you have given ketamine to sedate the child because it's a little over child, an older child not able to cooperate, you have sedated the child with ketamine and you are doing the caudal block. How do you know that it is acting before you allow the surgeon to paint and drape and start the surgery?
Hemodynamic parameters.
Hemodynamic parameters.
No
I
incision.
told you it is ketamine is given. So child may already have tachycardia, some amount of all that. Caudal block acts on which part of the vertebral spinal cord?
Sacral region, sir.
Sacral, and if you give a little higher volume, lumbar, lumbosacral regions, isn't it? So what are the effects produced when the lumbosacral block is positive or successful? What will happen to the cremasteric reflex in the male child? Have you heard of cremasteric reflex?
Yes, sir.
How do
Yes,
you
sir.
do that? Stroke the inner side of the thigh, and if the scrotum contracts, it is positive. Okay? That means the caudal block is not effective in male children. Okay? So when you stroke the inner side of the thigh, the scrotum should not contract. If it doesn't contract, by your block is successful. On the contrary, if the scrotal sac contracts because of the true contraction, I mean the scrotum contraction is a failed block. Whereas in female children, you don't have a scrotum. So how do you test? It is the anal sphincter relaxation. So if you just look at the anal sphincter, it will be widely relaxed, both in male and female. That's also another method of checking. Okay. Right. Sorry. Here also I have not. So here you can see what is shown here, the right-sided supracondylar fracture. What are the treatment options?
Either closed reduction, sir, or open reduction in internal fixation.
Closed reduction and pinning. Is it necessary to treat it as an emergency? Yes,
Mon-
because may sometimes compress the brachial artery, lead to limb ischemia. So many orthopedic surgeons will hurry you, saying that patient is likely to go in for limb ischemia because the radial pulse is not felt. Then it becomes an emergency. Okay? So supposing this patient, 8-year-old boy, after coming back from school, he had some snacks. He goes out to play. He falls down, and he has the fracture like this. How to manage this patient? He is brought to the ER. He is in
the
acute
full,
pain.
we have to take as a full stomach, and we have to give anti-aspiration prophylaxis with metoclopramide
Hmm.
or
Hmm.
Emised can also be given.
Hmm. This is an emergency with a threat to the limb, possibility of limb ischemia, but there is a full stomach scenario. Okay. So what is the best management you can do? The
Regional
8-year-old boy.
8-year-old boy.
Can you think of some blocks here for upper limb?
Yes, sir. Axillary now block.
Axillary or supraclavicular. Then you have to develop first a rapport with the boy. Okay, tell him and then give him some painkiller like paracetamol, reduce the pain, and then to identify and give a supraclavicular because lifting the hand and positioning for axillary block will be difficult. In a child, that too with an injury, if he is in pain, giving axillary block is a difficult proposition. So best will be to go for a supraclavicular block and block the upper limb and finish it off. Okay? That is the safest method to avoid aspiration. Otherwise, you have to go for rapid sequence induction and intubation. That is the safest method. And before extubating, you try to empty the stomach with the Rayleigh tube. That is what you have to do. And here, what is shown here, what is the classical description for this? This is an adult patient. Injury at the wrist level. Have you not seen this in ortho? Near hospital? I told you the first slide, I told you trauma, what are all the cases kept? Only supracondylar fracture. What was the other thing I have given there?
Foley's fractures.
Foley's fracture. Why so much delay in answering this? I understand. And what is the description of Foley's fracture? UG ortho, they have
Fork
not taught you
deformity.
this.
Fork
Dinner fork
deformity.
deformity. This is called the dinner fork deformity. All the fingers act as the fork of the dinner fork. Okay, and this is the bend that is there. This is called the dinner fork deformity. And so, supposing they want to reduce this and apply a cast or put a pin just like this, it usually happens in elderly patients. Okay, so they may have so many comorbidities. Supposing it's a patient who is very obese and they want to do a reduction and patient has eaten. Is it as an emergency like your supracondylar fracture or this Colles fracture, can it wait?
We can wait, sir.
It can wait. There is no urgency about Colles fracture because there is no threat to the blood supply to the limb. Only thing, patient will have pain, so you can give a supportive slab or a cast and wait till the patient is better to be taken under elective surgery. And you can do it under upper limb block. Here you can give easily an axillary block because you can lift the hand and place it in the position and the adult will cooperate. And or you can do it under intravenous induction and mask ventilation with spontaneous. That is what we normally do. So it is just pulling the hand and resetting the broken parts and just applying aspirin. Okay, so this is one. And in very critical, for example, if a patient has a cardiomyopathy with a poor ejection fraction and you don't want to give GA, may cause hypotension or some other cardiac problem or worsen the cardiac problem. Local infiltration into this swelling itself has been one of the methods of giving anesthesia. Okay, so you can just inject local anesthetic 1% xylocaine 5 to 10 ml into this joint, and that will give complete relief of pain as well as the procedure can be done under wound itself. Okay. So three options for this collis fracture is upper limb block in the form of supraclavicular or axillary block, intravenous induction with an induction agent and an analgesic like fentanyl if the patient is well starved, and application of face mask and allowing the patient to breathe spontaneously, gas, oxygen, and the volatile, and allow the surgeon to reduce the fracture. Third is infiltration into the wound itself. These are the three options for anesthesia. Now, a 8 years old boy weighing 43 kgs posted for adenotonsillectomy for treatment of snoring and mouth breathing. How to analyze this case? What are all the challenges in this case?
Pediatric age group
Pediatric
and
age group,
anticipated difficult airway since
anticipated difficult airway.
they might be OSA or under tonsils, adenoid tons. Since it is adenoid and a tons.
Okay, then is the
This
weight of the child normal for his age?
No, sir.
How do you calculate the correct or expected weight of a child above 5 years but below 12 years? What is the formula to use to calculate the weight?
Is less than more than 5 years is weight is equal to age into 3 plus 7. Less than 5 years is age
No,
into 2
I'm
plus
here
8.
according to this case, Soluma. What is the calculation for what should be the expected weight in this?
In
He
this
is 8
boy
years old.
is 8 years old.
What should be the expected weight?
31, 31.
4 times the weight, age. Okay, that is the calculation. Above 5 years but below 12 years, age into 4. That is age in years into 4. That is the normal calculation. So 8 into 4 it should be 32 kg. But here the is 45 kg. So that is the first thing that should try to always compare calculate the correct expected weight. So here patient is more obese. Second, he is a pediatric patient. Third, it is a surgery where you have to share the airway with the surgeon. Four, patient has history of snoring and mouth breathing, which may be a part of OSA also. Okay, that is how you analyze this case. So 8 years old boy likely to be apprehensive and cooperative. Patient overweight because of his age. Snoring and mouth breathing need to rule out OSA. Challenges of sharing the airway with the surgeon. Okay. Any special concerns in this case?
Bleedings or bleeding and
History
airway
of recurrent
obstruction.
URI,
Airway obstruction.
LRI, severity of OSA, any associated syndrome, possibility of difficult airway, history of any bleeding disorder, or any spolinapnea in the context. Adenotonsillectomy mostly done as a daycare procedure. Hence, all free of evaluation investigations are done as outpatient. You printed guidelines and free of antibiotics. How do you anesthetize a patient for tonsillectomy, adenotonsillectomy? Tell me step by step.
Then we standardized IV induction with If IV
After
access
thorough
is there,
pre-op
we are
evaluation and adequate starvation, this is how you should start in the examination. Supposing they ask you, how do you anesthetize a patient? Then you have to say, after thorough pre-op evaluation and adequate starvation, if any pre-medication is needed, fetal anesthesia, not the anesthesia is common in this area. Pre-medication can be, what are the pre-medications preferable for this case?
mm,
So oral syrup midazolam 0.5 per kg or syrup triclopraz 30 to 50 milligram per kg. Sometimes you can give intranasal dexmedetomidine 1 to 2 microgram. After pre-oxygenation, intravenous injection done with IP propofol. Patient is paralyzed with a tracherium or tracherium. Intubated nasally or orally as per surgeon's requirement. So you have to discuss with the surgeon, because some surgeons want oral intubation if they are planning adenoid removal, and some surgeons prefer nasal intubation for tonsillectomy. So you have to discuss it with the surgeon and decide whether you are going to intubate with a nasal trach tube or a oral trach tube. And analgesia is multimodal. Avoid use of or use minimum narcotics if there is a proven OS is there. Better to minimize the use of narcotics. Maintenance with oxygen, air, and volatile. Reverse after completion of surgery. Ensure no foreign body is left, like cotton balls or gas pieces in the oropharynx. Then suck out the secretions. Extubate the patient in lateral position or immediately turn the patient to post-tonsillectomy position after extubation. So this is how the anesthesia should be described. What is shown here and who designed this?
Boyle Davis mouth gag.
Boyle Davis mouth gag. Okay. Designed by who is Davis and who is Boyle? That is a history question. Both belong to the same country or different country? Same person or different persons?
Different person.
Different persons. Okay, different country also. Davis is Griffith Davis from US. He was also an anesthetist. He was the first person to design this blade and this mouth gag. Boyle went to US. He copied that and he brought this and modified that. Okay? So originally designed by Griffith Davis, a US anesthetist, then modified by the same person who made the anesthesia machine, Henry Edwin Gaskin Boyle, and that is the reason why it is written with a hyphen, Boyle and Davis mouth gag. Okay? What is coronar's clot? In which condition it happens? What is the risk? How is it managed?
It is detected post-mortem
Sir,
post-mortem conditions after a tonsillectomy, adenotonsillectomy in the tonsillar fossa. It indicates severe blood loss.
Severe blood loss.
Hypovolemia and
Even in patients with normal bleeding, it can happen. It is not necessarily that patient should have bled so much to have this. It happens, it's a normal clotting mechanism. So it is an occult blood clot left behind in the nasopharynx, posterior to the soft palate. So surgeon misses to remove that properly. Then occurs in surgeries in the area of nasopharynx or when there is a trauma to the nose. And adenotonsillectomy is the most common cause for this clot to occur in the nasopharynx. It may cause a potential airway obstruction if you have not removed this clot before extubation properly. This can come as a block and obstruct the clotic opening. So management is nothing but careful suctioning of the throat and nasopharynx under vision with a direct laryngoscope. So always any oral surgery, at the end of the surgery, before you extubate, put your laryngoscope and then visualize the oropharynx, and also try to see behind the soft palate. That is the area this coroner's clot will be sitting. And it is given that name coroner's because it was identified in post-mortem. After death of the patients after tonsillectomy, they found there's a huge clot going and sitting near the glottic opening. So coroner is nothing but a person who does the post-mortem. It's a forensic person. So that is how they found out. So this is how you have to do. So by flexion of the neck during laryngoscopy, you can bring the clot more anterior. You can remove it easily. So these are all the points that you have to remember. What are the challenges in anesthesia for post-tonsillectomy bleeding and how to manage? This is another common question in this particular case scenario.
It's
You have operated and sent the
repeat
patient to
surgery.
the post-op
Repeat
ward. Hmm?
repeated surgery. I mean,
Repeated?
repeated surgery adds to the risk.
Repeated
of
surgery.
It is
Yeah,
considered
first
as a full stomach.
patient has undergone adenotonsillectomy. You have successfully woken up the patient, extubated the patient. You have sent the patient to the ward, and you get a call from the ward that patient is restless. And when you go and see what will be the picture if there is a rebleed and bleeding after the surgery in the post-op ward. That is what the question.
The child would be hypotensive, sir, with tachycardia.
Child will be hypotensive. Will it be restless or not? Because there is a continuous use, it is irritating the child. It is happily swallowing in, part of it will be coming out from the mouth. And so the child will be quite restless. And because the child is constantly crying, parents will be anxious. Yeah? And
Yes.
when you see the child, depending upon the blood loss, it may have become pale and capillary refill time. What will happen if there is a severe bleeding? What is the normal capillary refill time?
It is less than 3 seconds, sir.
Less than 2 seconds. Supposing it is 4 seconds or 5 seconds, what does it indicate?
The perfusion is reduced.
Hypovolemia.
Hypovolemia.
Severe hypovolemia. Okay? So pulse will be, what will be the pulse rate in hypovolemia?
Tachycardia would be there,
Severe
sir.
tachycardia will be there. BP may be there. Okay? That is the situation that you will see. So in that situation, what will you do? That how to manage? This is a very common scenario question they will ask you in the exam.
So,
We
What
need
is the
to
first thing you will do? Supposing patient's capillary refill time is 5 seconds. Patient is looking very pale
we'll
and
start IV
his
fluid,
pulse
sir.
is
Immediately
140.
resuscitate the child, sir. With
Huh?
immediately resuscitate the child with IV fluid, sir. Starting
Very good.
blood products, if
Then?
significant blood loss is there.
Order for blood,
Order
not blood products. Just go for blood. Packed red blood cells because it is a frank bleeding. And so the surgeon may like to explore and arrest the bleeding. So restless child, anxious parents, possibility of hemodynamic instability, problem of full stomach because the child would have swallowed some of the blood that is oozing out. Okay? So it is to be treated as a full stomach case, and it may have intubation difficulty because the oral cavity will be full of blood and there may be edema, and that may be causing a poor vision when you put the laryngoscope. So these are all the pictures that you will see. So what you have to do is assess the hemodynamic status, arrange for blood, have a helping hand, and start giving fluids, deoxynate, RSI, use oral endotracheal tube. Even if the patient has undergone adenotonsillectomy, never re-intubate with a nasal route. Use only a oral ET tube, and that too one size smaller. And after intubation, try to empty stomach with NG tube after extubation. So after intubation and induction of anesthesia, The surgeon will again put a mouth gag and try to identify where the bleeder is and either ligate it or cauterize it to stop the bleeding. Okay, and again you have to keep a awake patient, and too much of narcotics should not be used because patient will, especially if they are hemodynamically unstable, be careful with your narcotics. So that is what you have to show. So amphotericin, this is just to ask a few questions on the neonate because it's a neonatal emergency that is done. So patients, what is the definition of a neonate?
Uh,
To
the
what?
the child till 28 days of
28 days after birth. The
birth.
baby is a neonate, is 4 weeks old or younger after birth. What are the common issues in neonatal anesthesia?
Altered airway anatomy,
Hypothermia.
sir.
Hmm.
More
Hypothermia.
prone for hypothermia
We see hypothermia.
and
Liver and renal systems are all very fluid.
underdeveloped, immature.
So thermoregulation is not good, and neonates have greater body surface which get exposed to operative field and moisture. And general anesthesia also inhibits central thermoregulatory function. Glucose neonates more prone for hypoglycemia because they don't have glycogen storage and they have impaired glycogenolysis and gluconeogenesis. And what are the fluids of choice in neonates? Can you give ringer lactate, sodium chloride, or dextrosaline?
Dextrosaline is
Dextrose with ringer lactate, the fluid for maintenance to prevent hypoglycemia. Okay, so you always add dextrose to the ringer lactate in children, especially in neonates. Fluid bolus will be given using normal saline or ringer lactate up to 10 ml per kg without glucose. So if you want to replace fluid loss, you just give plain normal saline with ringer lactate. But for maintenance, you use dextrose with ringer lactate. And positioning, intubation and airway management can be difficult because of the changes in the airway, large red floppy epiglottis, more cephalad position of the larynx, and easier to intubate with a neutral or slightly flexed position. What is torsion 789 rule for intubation in a neonate? Any idea?
no, sir.
Okay, the rule is used for the depth of endotracheal tube placement in neonates. Unlike adults, where you can pass the tube for up to 19 or 20 centimeters, according to this rule, 1 kg neonate should have an endotracheal tube shaped at 7 centimeter at the gum level. For 2 kg, 8 and 3 kg, 9. So this is the maximum length you have to infuse, otherwise you will make it endobronchial. So this is the guideline for introduction of the tube in the neonate up to safe level without going in for endobronchial intubation. So you can also use weight of the baby plus 6 centimeter as a rule. So supposing 1 kg child, 1 plus 6, 7, 2 kg weight like that. So what size ET tube is used in neonates? That is the circumference or the internal diameter. Usually 3 mm ID uncuffed endotracheal tube is used most of the time in children with 1 kg weight. And if it is less than 1 kg, you have to use 2.5 uncuffed tube. Serious changes, neonatal myocardium is less compliant than adult myocardium. And it is rate dependent. Cardiac output is rate dependent in newborn. And circulating blood volume and blood loss have a volume of 90 ml per kg. Total volume of the blood volume will be 90 ml per kg. So if a child is only 1 kg in weight, it will have only 90 ml. And preterm babies will 100 ml per kg. And the allowable blood loss. This is common question they may ask you in the exam. So estimated blood volume multiplied by HI and that is initial hemoglobin plus final hemoglobin divided by initial hemoglobin. That is the rule or formula that you have to use. Estimated blood volume multiplied by initial hemoglobin minus final hemoglobin divided by initial hemoglobin. You will get the allowable blood loss. Respiration, metabolic requirements. So these are all the changes. Pharmacology and drug metabolism, renal and liver maturation occurs only after 6 months of age. So in neonates, they have inability to metabolize the drug, so easily you can overdose the children. Investigations needed are CBC, urea electrolyte, coagulation profile, blood glucose, LFT, etc. And transitional circulation, already we have seen neutro, the flip-flop circulation is otherwise also called transitional circulation, switching from adult circulation to fetal circulation. Challenges in management of a neonate with either a tracheoesophageal fistula or a congenital diaphragmatic hernia or this sort of convolution. They are all challenges to neonatal anesthesia, pre-op management, fluid management, etc. Drop, prevent hypothermia, place baby in warming mattress, attach routine non-invasive monitors, IV induction with IO or inhalation with CO, muscle relaxant, natracarium or citracarium, plain EPQ, intubation and controlled ventilation, maintenance with oxygen, air and CO, and a single shot caudal block or bupivacaine with 0.2%, 1 ml per kg can be given as a supplemental anesthesia for any pneumococcal diseases. This is another case scenario. What is shown here?
Phimosis.
Huh?
Phimosis.
Phimosis. Phimosis is a picture. See, there is an opening here, not in here.
Hypospadias.
Hypospadias. This is different types of hypospadias. Okay, that is another case which can be kept in the exam. What is hypospadias? Hypo means below, spadias means opening. Opening which is not in the normal position. So, urethra opening proximally along its course and not in the tip of the penis. What is the anesthetic management for repair of the hypospadias? Have you ever seen a case being done in your experience so far during training?
No, sir.
No. Okay. Yeah, that makes it a difficult choice. Routine pre-op assessment should be performed. The child may be emotionally upset due to repeated visits to the theatre for stage procedures. So this is not done as a single procedure. Usually, first the procedure that is done is called cord release. Then second only the urethral formation will be done. Okay? So the stage procedure and general anesthesia supplemented by caudal is treatment of technique of choice. You can use inhalation or intravenous induction agent for anesthesia. Maintenance respiration, no need to control because this is more or less a surface procedure. And you can use an LMA also for the child too after that. And caudal, the dosage is like this. And we can prolong the caudal for post-op pain relief. We can add 1 to 2 micrograms of vitamin local anesthetic. Or you can use a continuous caudal catheter for infusion of local anesthetic. What is the dose of morphine infusion for this child? Because sometimes this is a very painful procedure. Children may need morphine. So infusion rate at the rate of 0.2 ml per hour. It's 4 microgram per kg of morphine per hour. Bolus dose 1 ml 20 microgram. So you take 1 milligram of morphine and dilute it with 50 ml of saline. Then you will get Uh, how many micrograms you get? One milligram morphine is how many micrograms?
1000 micrograms.
Any 1 milligram drug is 1000 micrograms. So if you dilute it 50 times, how many micrograms will be there in 1 ml? 1000 divided by 50. This is the answer. 50 micrograms. So you have to take 1 milligram, not 1 ml. 1 ml of morphine is 10 milligrams.
10 mg.
Okay, I don't know how many of you have seen morphine ampules. 1 ml of morphine is 10 milligrams. You take, you dilute that first to 10 ml so that you will get 1 milligram per ml, and then further dilute that to 50 ml to get 20 microgram per kg. So you can give 20 microgram per kg as a bolus and then continue with 4 microgram per kg. This is like a patient controlled analgesia, but in pediatric patients they cannot control, so this is called nurse controlled analgesia. Okay. What is this block?
Phenyl,
Hmm?
phenyl block.
Phenyl block. Louder. So how many nerves are there? What is this? Dorsal nerve of the penis. Okay. So you have to block both the nerves. And what is this? What is the difference between this and this? This is a phenyl block blocking only the dorsal nerve of the penis. Whereas here this is called the ring block given at the root of the penis, where you go all round on the dorsal aspect as well as on the ventral aspect to block the sensation of the entire penile shaft. Okay? So this is called the ring block. So this is how it is all given, and this is the ideal technique for circumcision in children. Other option is caudal block also. And the common questions you can expect is, supposing a child has recently recovered from a URI or LRI, how to anesthetize, you have to say this is the best technique, but a small child may not cooperate. So can you give ketamine in a child who has recovered from LRI or URI?
Is recovered, sir. Hello, sir. Couldn't get the
Can you
question.
give ketamine for a
Can give.
child who has recovered from LRI or URI?
Yes, sir.
Yes.
Can be given.
What is precaution you have to take?
Secretions. We have
You have to give anti-sialagogue well in advance to prevent any secretion. Otherwise, that may stimulate a laryngospasm because the reactive airway is there in a recently recovered child. Okay, so that is the answer that is expected. This is Burgess disease or TAO. So common causes are smoking, hypertension, and diabetes and hyperlipidemia. And surgical management of TAO, I don't know, many of you would have not at all heard of this also. Sympathectomy, enterectomy, amputation. And this is not very common like what we saw those days, because people have now become aware of the problems of smoking. So this is mainly caused by excessive smoking. And the differential spinal assessment is one which we used to do before the sympathectomy, where we used to give a lower concentration of local anesthetic. That is, 1% xylocaine will be injected 2 ml into the subarachnoid space. That will not be sufficient to produce any motor blockade, but it will produce autonomic and to some extent the sensory blockade. So once that autonomic blockade has happened, there will be good vasodilatation in the lower limb. And you have to test the temperature of the skin in the limb before and after the injection. And if there is an increase in 1 degree centigrade of the skin temperature, that patient will benefit by doing a lumbar sympathectomy for augmenting the blood flow to the limb without going in for amputation. Okay? This is what is being done. And strabismus, because we have discussed that earlier. So this is a very common thing. What are the important pre-anesthetic evaluation you have to do? This is a case which can be kept in the exam very easily.
Any other
Hmm?
associated
Any
muscular disorders
associated
like this?
muscular disorders or family history of
Family history of
malignant hyperthermia. Okay? So isolated or secondary to muscular disorders is associated with muscular disorder. What is the risk? This is where malignant hyperthermia.
malignant hyperthermia.
Indications for surgery, not only the correct cosmetic reason because the eye is deviated, but also to have correct binocular vision. Okay, that is the reason why. What are the coexisting anomalies a patient with squint can have? Strabismus.
Coexisting arrhythmias.
Congenital heart disease, cardiomyopathy. Okay, so look for these. What are the coexisting CNS anomalies the patient may have? Associated cerebral palsy, meningomyelocele, hydrocephalus, craniofacial syndromes. They also may have. So see, this is case. This is a case of cerebral palsy. So look up for all these things. And that will be very obvious if they have them. Applied anatomy of the orbit may be asked if you get a case like this. So you have to know all about this. What are the four-sided body bronchi? It's a pyramid-shaped cavity. What bones form that? Medial wall, lateral wall, apex, etc. And what is a normal intraocular pressure? And in strabismus surgery, they resect the overacting muscle and reposition that muscle to correct the deviation. Okay? So oculocardiac reflex pathway is the common question, which is a complication. What happens in oculocardiac reflex?
On sudden traction produced due to orbital stimulation. It is a trigeminovagal reflex. It causes sudden vagal activity and bradycardia, and sometimes even
Bradycardia. So that is the effect. Bradycardia occurring because of the pulling on the orbital muscles. So the afferent pathway is by long and short ciliary nerve
trigeminal nerve.
with the ciliary ganglion going to the basilian ganglion is the motor nucleus. And there is an interaction with the vagus. So the efferent pathway is by the vagus nerve. So afferent is by trigeminal, efferent is by vagal. Oculoemetic reflex. Post-op nausea vomiting is very, very common after squint or strabismus surgery. So again, afferent and efferent pathway you have to say. It is the afferent pathway, again the same pathway. So impulse from intracardiac muscle, vestibular nuclei, 3, 4, and 6, medial axonal formation and reticular formation, close proximity to vomiting center. So that is stimulated to produce nausea and vomiting. So here you can see the ocular pathways, medial longitudinal fasciculus, reticular formation. So just like the vagus nucleus being adjacent to the trigeminal, this vomiting center being adjacent to the vestibular ocular pathways that causes the vomiting. So that is how the oculoemetic reflex occurs. And of course, there are other reflexes called oculorespiratory, and that is not very, very important. They say GD, that is supraglottic airway preferred for surgery in the for strabismus is flexometallic LMA. This is not a normal LMA, this is a flexometallic LMA. It can be bent like that, or you can use the ray tube. You are planning to intubate, the tube of choice for DA for strabismus surgery is oral ray tube. And This is the cup flow tube. What is force duction test?
It is used to
Huh?
distinguish. It is used to distinguish whether the establishment is due to any mechanical cause or any muscular.
So whether it's a paralyzed muscle or a non-paralyzed muscle. That is the difference to find out. It's a test done by the surgeon intraoperatively during skin surgery to distinguish any restriction in the movement due to mechanical causes or increased muscle tone. Okay? So how can anesthetics help in when the surgeon is doing the force duction test? And you can use neuromuscular blocking drugs to produce complete muscle relaxation. This will paralyze and relax the muscles with increased tone, but it cannot relax muscles restricted by mechanical causes like fibrosis. Okay? So that is how you can find it. What is bell sign?
Upward rolling of the eyeballs
Upward rolling.
down.
Sometimes the eyeball remains rolled up, known as bell sign. So this is the problem with it. How to avoid this problem? It happens in
Correct
lighter plane
anesthesia,
of anesthesia,
correct
so
depth of
adequate depth
anesthesia.
is important. And achieved by inhalation agent in adequate concentration or propofol infusion, that will be very good. So that is all.